So I'm Dr. James Hopkinson. I initially trained as a GP, qualifying in 2002. I worked as a clinical assistant in sports and exercise medicine in Nottingham with Professor Mark Batt. I worked at Nottingham as a consultant in sports and exercise medicine for approximately 4 or 5 years until I became chair of the local commissioning organisation, when that gave me a conflict with the trust where I worked, so I stepped away at that point. And since then, I've continued working as a GP, but I've also been in leadership roles through the iterations of commissioning organisations until last year, when I became medical director of the local medical committee. I'm also the clinical director of our local primary care network. So if I was trying to think about how I actually practically would go to deliver a SEM clinic or provide a solution, I think, again, it really starts off with what is the local need. I think if I focus very much on what I think is a good sports and exercise medicine service as my output and my outcome, I think I might miss the point of what the opportunity is locally. In my head, I do have a feeling of what good looks like, but I also need to be very, very aware of what the local politics and the local landscape and finances and what is currently being delivered in the region. So I think starting for a really strong understanding of what currently is available and delivered is a good start. And then I think I'd spend a lot of time trying to talk to the local stakeholders. So there'll be a group of people who are going to be supportive, and then you need to get hold of them and get them on your side so that they can help you. But there's also going to be people who are threatened by you setting up this service. So they may be community MSK providers, physiotherapists, even the orthopaedic surgeons. You may find that there are challenges and there is suspicion about what you're doing and whether it will impact what their roles are. So understanding who's on your side and who isn't on your side and who you can work with to try and bring them along, I think is really important. Having done that, I think it's worth understanding what the roles are that you can add value to, where it is you can save money, where it is you can deliver better care, how you can improve waiting times, which are the consultants that feel that you're going to work well with you. I think it's very unlikely you're going to be able to walk in and create a complete standalone service all on its own. I think those are really difficult things to do. So the opportunity really is to build on what might be already there and work with people. I also think that if you had the opportunity to bid for a service, you need to have a turnover. You need to have money behind you, and you need to be able to demonstrate that you're resilient, financially resilient. And if you're an individual, you won't have 3 years of being able to demonstrate you've got a turnover of £10 million or whatever the number is that is a multiple of the contracts you're looking to get. So one of the first things the commissioners would look at if you were trying to tend for a contract is, as a provider, are you resilient? Are you going to go bust? Will you still be here in 5 years' time? So if you're a sole provider, then it means your risk of going off sick is very high. But also, if there's costs to the contract that you haven't considered, are you going to be able to absorb those costs without going bust and leaving them without a service? So that is a really big hurdle. And so one of the ways around that is to partner with current providers who might be able to provide you with an umbrella of cover so that there's some positives for both parties. So they provide a wider basket of services, they spread their risk more widely, but you can use the financial backing of that organisation to get you across that line. That's a difficult line. So considering that you've got yourself in a position where you're able to provide and you've worked out what to do, I think writing the business case is relatively straightforward. Being able to demonstrate the benefits of SEM is relatively easy. The documents are already written by the faculty. There's really good information out there about what the opportunities that generally sports and exercise medicine provide. The key bits for me is what is it that we're going to be able to do here and how, and what are the outcomes we're going to be able to produce. And the more specific we can be, the better. And those specifics will be in numbers, i.e. how many people can we see in a unit of time, how can we reduce waiting lists, what's the time periods we can do that by, and what are the costs. And are those costs that we can set against savings that we've made elsewhere? So I think we need to be also very mindful that when people think about costs, they see that the service that they're potentially providing being cheaper than the current services that are already out there. So let's say you cost up your service and you say, well, the current orthopaedic service delivering knee care costs a certain amount of money. In the studies that I can provide, we could look at the same cohort of people and we could provide the care at a cheaper level, maybe reduce the number of people going to theatre. That's all very well as long as we stop these surgeons from operating on anybody else. So the fact that we've managed to take a cohort to one side and manage their care more cheaply, if those surgeons carry on working at the same rate, all we've done is added to those costs as opposed to replace those costs. And as a commissioner who's got a fixed envelope to play with, they're going to struggle to say, we've got extra money to add that to it, even though the care is better or could be better. It's going to be how do we integrate all this into a single pathway that is going to save money throughout the process. So if I was trying to set up an NHS sports and exercise medicine clinic in a new area, the key stakeholders for me are going to be the commissioning organisation, the ICBs. I'll be trying to find out who are the commissioning leads for musculoskeletal care from the ICB. There'll be a manager and there'll be a clinical lead there. And I'd try and understand what their viewpoints are, understand what their strategy is, and understand where the commissioning cycle is from their point of view. I would definitely talk to the local providers, so that might be the local trusts, there might be community providers. I'd understand what roles they currently deliver, whether there's opportunities to work with them or whether there's gaps in services that we could deliver separately. I'd also talk to the trusts, because the trusts are big spenders. They've got the largest budgets across our health economies, and they're also delivering a lot of musculoskeletal care already, and they're spending a lot of money on it. And there may be opportunities for us to work with them to help them deliver cost savings from the trust point of view. So I think I would go through all of those stakeholders. I would also think about the people who might be our allies and might be feeling threatened by setting up a service. So who are the people who are currently delivering musculoskeletal care? Are they going to be supported by this service? The orthopaedic surgeons may be very positive about having some musculoskeletal services alongside them that might help them spend more time in theatre, but they also might feel threatened that they might lose or have risk to their jobs, for example. Local physiotherapy services might see risks rather than benefits. I know that they're all people that can work together to be able to deliver that care, but there's sort of thresholds that we need to get over so that everyone feels not threatened by this, because people who are currently in that environment and currently working there will hold more sway than me coming in as a new person trying to set up a service. So I think I'll be trying to go across the whole landscape to understand other people's positions, other people's thoughts, and use those people to help me. So if I was going to try and set up an exercise medicine programme, the key people I'd be trying to talk to would be the ICB and understanding what their strategies are and what the plans are already currently in place. I would be trying to find out what's currently being delivered. I would want to know which areas to prioritise. Are we talking about cardiology here? Are we talking about respiratory, neurology? There's multiple different areas, and ideally we could provide a service across all of those. But actually we're going to need to get our feet under the table somewhere and start delivering something. And we may find that there's already money available for certain areas, like cardiology generally has a well-established programme for exercise programmes post heart attack, post other problems. Pulmonary rehab programmes already exist. Is there a way we can tie those together and to provide support, deliver better outcomes? So I would be talking to the individual services, I'll be talking to the specialists involved in those services, so the cardiologists, the respiratory consultants, neurologists, for example, and what they see as the gaps or what could be done better, what could we improve on, and how can we help them deliver better care. Because what they'd like to be able to do is be able to be in control of a unit that delivers exceptional care. They're usually driven by quality when you speak to the specialists, whereas the ICB is going to be delivered by finance and money. So they're clearly both important, but if you can hit both targets, that would be really helpful.